अच्छा
उसको ये खोल के दो। हाँ अब होना चाहिए। ये पकड़े ऐसे पकड़ने सामने तो वो आया था ना सुबह। सुबह आया था बंदा सो सामत भाई। वो जब यहाँ पहुंचा 9 बजे। कल जो आया था सर्वे करने उसने बनाया था प्लान वायर। जो लगाने आया इंजीनियर उसने बोला नहीं वायर नहीं लगेगा। अब उसको वो कैंसिल करके नहीं क्रिएट की वायर डबल सुकर इवन फोन वो ही आज लग गया। वो नहीं ये नहीं आना चाहिए प्लस यू प्लस हाँ जगह नहीं थोड़ा सा बदल नहीं
obstructive defecation syndrome, rectal varices, solitary rectal ulcer syndrome, and fistulas.
जूम कर
Physiology of hemorrhoids. Junctions are normal structures which are made of vascular channels, including arterioles, venules, and sinusoids, connective tissue, and smooth muscle, that's the trace muscle. They're responsible for the anal continence. Now, what are hemorrhoids? Hemorrhoids actually are the downward displacement of anal cushions, the varicosities, but they are actually not caused by portal hypertension. They are just the venous engorgements. Hemorrhoids occur because of degeneration or weakening of supporting tissue, which occurs with age,
मैंने बंद किया
constipation,
पहले ठीक कर लो
constant straining,
मैंने ही बंद किया तू कुछ नहीं करना
or chronic cough. This causes excess shearing force on the anal cushions, which causes their downward displacement. Vascular hyperplasia and engorgement. There's increased arterial flow and decreased venous return, which causes the submucosal sinusoids to become dilated and tortuous. There's increased in inner canal pressure, which may be increased in intra-abdominal pressures, for example, during coughing or pregnancy, or increase in anal pressures in situ, for example, during straining or passage of hard stool. Now, there are some contributing physiological factors like arteriovenous anastomosis, which are present in the submucous of anorectal canal. Now, there is a theory that is sliding inner theory that suggests that hemorrhoids are not actual varicosities, but they are downward displacement of anal cushions.
I'm in audience
There is chronic constipation and straining, which increases the shearing force and causes downward displacement of anal
zoom
cushions, which causes repeated bleeding. Now, in pregnancy, there is increase in intra-abdominal pressure, which causes vascular engorgement due to decrease in venous return, and also there is the hormonal increase of progesterone, which causes muscle relaxation and vascular engorgement. As we can clearly see here, the proper and the normal positioning of anal cushions is at 3 o'clock, 7 o'clock, and 11 o'clock position. That describes the cause that why hemorrhoids are normally found at these positions. Now, we come to the grading of hemorrhoids. In grade 1 hemorrhoid, there is only the bleeding and there is no prolapse of mucosa. In grade 2 hemorrhoids, there is prolapse, but the prolapse is spontaneously reduced. In grade 3 of hemorrhoids, there is prolapse which is manually reduced. And in grade 4 hemorrhoids, there is permanent prolapse which cannot be reduced. We come to the pathophysiology of some symptoms that are found in hemorrhoids. There's bleeding due to the dilated and fragile mucosa that overlies the engorged vessels. There is prolapse due to separation of connective tissue and weakening of smooth muscle, that's the trace muscle. Internal hemorrhoids lie above the dentate line, which are painless. But the external hemorrhoids that lie below the dentate line are painful because they have somatic innervation, especially when they become thrombosed and strangulated. Thrombosis. Now, why? Why does thrombosis occur in hemorrhoids? There is stasis of blood, as we have discussed that there is decrease in the venous return. So this predisposes to the thrombosis. And there's mucosal discharge. That is, exposed mucosa produces mucus, which leads to the discharge. Now, we will discuss about the pathophysiology of anal fistulas. The origin of anal fistulas is the most accepted theory about it is cryptoglandular theory. Now, what does this theory say about it? It says that anal canal, especially the dentate line, is rich in anal glands, and they are the ducts open into the crypts. Now, when these ducts get blocked, they get infected by the bacteria, which leads to the abscess formation. The sequence of events that occur is as follows: obstruction of anal canal gland and bacterial infection, which leads to separation, abscess formation, and abscess drains spontaneously or surgically. Persistent tract with epithelialization occurs, which is called as fistula in anal. This accounts for 85 to 95% of fistulas. Now, there are two states. First is the formation of abscess by the blockage of duct and infection by the bacteria. Second is the persistent epithelial tract that is caused by the granulation formation, later followed by epithelialization. Now, the path of spread of the fistulas. There is intersphincteric fistula that stays between internal and external sphincter. There is transsphincteric fistula that penetrates the external sphincter, and there is suprasphincteric fistula and extrasphincteric fistula. The difference between suprasphincteric fistula and extrasphincteric fistula is that in suprasphincteric fistula, as you can see here, the infection travels between the sphincters first. It crosses over the puborectalis muscle, but in extrasphincteric fistula, the fistula directly drains above the puborectalis muscle, which mostly occurs due to Crohn's disease or trauma. Now, why do fistulas persist? There's a constant infection source through the anal canal that causes the fistulas to be reinfected by the bacteria. There's poor drainage due to the ducts that are small or tortuous. There is epithelialization due to the granulation tissue formation. The sphincteric movement, that is the constriction of the sphincters, doesn't allow the fistulas to heal. Now, discussing some pathophysiology of symptoms. Pain is caused by active abscess or active inflammation. Purulent discharge is present. Itching or irritation may be present. Recurrent abscess formation. There are some contributing conditions that are non-cryptoglandular causes. For example, Crohn's disease, tuberculosis, trauma, malignancy, radiation injury, and foreign body. Now we will talk about rectal varices. Rectal varices are dilated venules that are mostly caused due to portal hypertension. These are different from the hemorrhageal disease. The portosystemic connection present is that superior rectal vein is related to the portal circulation, and middle and inferior rectal veins are related to the systemic circulation. Increased portal pressure causes the dilatation of submucosal veins. There are some clinical features like painless large volume rectal bleeding, bluish submucosal bulbs, signs of portal hypertension, for example, hepatosplenomegaly, and the sites. As we can clearly see here, these are the dilated rectal varices. The superior rectal vein, which corresponds to the portal circulation, the internal ileal vein, which gives rise to the middle rectal vein, inferior rectal vein, that are related to the systemic circulation. Now, talking about the anal fissures, the pathophysiology is as follows. First, let's come to the proper definition of a fissure. A fissure is a longitudinal tear in the anal, usually posterior midline. These can be found anywhere between the anal verge and the dentate line, but not beyond the dentate line. Trauma due to the anadrome during passage of harsh stool or repeated diarrhea can lead to the tip. Now, what is the posterior location of these anal fissures? The important causes are that exaggerated shearing forces are present on the posterior wall of the anal canal. There is increased density of the longitudinal muscle extensions. And also, that there is the posterior wall is a watershed zone, that already there is the presence of less vasculature that causes it prone to the trauma due to ischemia, obviously. The tail leads to hypertonia of internal anal sphincter. There is the spasm that causes the ischemia of the posterior midline area. This leads to the non-healing chronic ulcer, as it already is a watershed zone. So the chronic fissure shows sentinel bile, hypertrophic papilla, and exposed sphincter files. As we can clearly see here, that most of the fissures are found posteriorly, some are found anterior. The percentage of posterior fissures is 90% and the anterior fissures is 10%. Now, there are some lateral fissures that may be present. Their percentage is only less than 1%. These may be Crohn's disease, ulcerative colitis, syphilis, tuberculosis, or leukemia. As you can see there in that picture, the posterior anal fissure has can be seen there. It has some corresponding parts. That is the hypertrophic annular papilla, the muscle fibers at base of the fissure, and the skin tag posterior most. Now coming to the solitary rectal ulcer syndrome. It is defined as disordered defecation mechanics leading to repetitive trauma, mucosal ischemia, and ulcer formation. What are the main causes that lead to the presence of solitary rectal ulcer syndrome? First of all, let me make you very clear that the solitary word used here is never solitary. These are never solitary in nature. And these are not the proper ulcers. So, now what are the main causes that lead to solitary rectal ulcer syndrome? Defecation or dysynergic defecation. What is it? Actually, when a person defecates, there is relaxation of puborectalis muscle and external anal sphincter. But here is the paradoxical contraction of puborectalis muscle, or it fails to dilate, or the external anal sphincter may fail to dilate. So there is excess straining which leads to downward displacement of mucosa. And mucosa becomes engorged and it gets traumatized by the passage of the stools. Mucosal prolapse. Bailey now focuses on this main part, that mucosal prolapse is the main pathogenesis of solitary rectal ulcer syndrome. So what happens is that the constant straining leads to downward displacement of mucosa. As it becomes engorged and thrombosed, there is increase in the ulcer formation. Local ischemia may occur. Direct trauma to the anterior rectal wall during the passage of hard stools, rectal hypersensitivity, and abnormal rectal compliance. Now, the fourth cycle is that dysynergic defecation due to paradoxical puborectalis contraction leads to mucosal prolapse that causes trauma and ischemia, that leads to ulcer, pain, that leads to more straining and worsening of prolapse. Now, let's come to the obstructive defecation syndrome. So, what it actually is, it's the functional constipation that is characterized by difficulty in rectal evacuation despite normal colonic transit. Now, what are the main causes? The anatomic obstruction, including the rectocele. What is rectocele? Rectocele is the herniation of anterior rectal wall into the posterior vaginal wall due to weakening of rectovaginal septum or the perineal fascia. It mostly occurs due to increase in the abdominal fissures. Internal interception of rectal mucosa occurs. This occurs due to increase in the pressures on tissue disorders that leads to the mechanical obstruction of passage of stools. Enterocele or sigmoidocele is the herniation of small bowel or sigmoid into the rectovaginal or rectovesical pouch. Pelvic organ prolapse. Now, there are functional obstructions as well. Dyssynergic defecation, that is the bronchopectalis paroxysmal contraction, which normally relaxes during normal defecation. Pelvic floor weakness, that occurs due to the weakness of levator and the muscles or the fascia below. Impaired rectal sensation that may be due to neuropathies or any other disorders. Secondary changes may be present. For example, rectal hypersensitivity, neuropathy due to straining, due to dental injury as well, reduced compliance. These abnormalities make stool evacuation difficult. Despite a normal colon, straining, incomplete evacuation, assistance, and feeling of obstruction.
Thank you, Answer, for this wonderful presentation. Now, I would like to call Dr. Idris,
BSc पढ़ा?
postgraduate BMC Srinagar. He will be presenting the hemorrhoids diagnosis and management.
Respected faculty members and dear friends, very good afternoon to everyone. I am Idris. I'll be presenting hemorrhoids, diagnosis and the management. So quickly on the definition, hemorrhoids are the vascular cushions composed of connective tissue, smooth muscles and blood vessels. These are located at the 7, 3 and 11 o'clock position, as the speaker before me said. The main function is they help to maintain the continuity and by sealing the anal canal. Hemorrhoidal disease occurs when these cushions enlarge, prolapse, and become symptomatic. So, briefly about the pathophysiology of the hemorrhoids. So, most accepted theory today is the sliding anal cushion theory. There occurs loss of supporting tissue, leading to downward displacement, increased arterial flow, which further leads to hyperperfusion and vascular condition. At biochemical level, there is the activation of matrix metalloproteinase, which results in the collagen breakdown, thrombosis develop, and the blood strangulates in the dilated plexus. Chronic inflammation leads to mucosal prolapse. So here is the histopathological image. You can clearly see dilated blood vessels and the fragmented muscles. So classification, hemorrhoids are classified into internal, external, as said. Uh, Classification of internal hemorrhoids is further divided into grade 4, grade 1, 2, 3, and 4. Grade 1 is when no prolapse is there. Grade 1 is present. Grade 2 is prolapse, but reduces spontaneously. Grade 3 is prolapse, requiring manual reduction. And grade 4 is irreducible prolapse, and there is a risk of strangulation in grade 4 prolapse. So, what are the symptoms of the hemorrhoids? Symptoms are painless, bright red bleeding during defecation. There is a prolapse sensation or visible